So the topic is varicose veins. This varicose veins can be asked as an essay in our university examination, and this topic is very important and it's actually lengthy. So if the management part also, the examination part also, there are so many points, but in this module I have just make it very simpler how to write for an essay in the university examination. So let's start. What is varicose vein? Varicose veins are dilated tortuous veins with defective walls. This is a simpler definition. Varicose veins are the dilated tortuous veins with defective wall. Coming to the classification part, after definition you have to write about the classification, and there are different classifications. So the primary basic classification is primary and secondary. Primary means it is happening due to congenital defect in the walls or congenital absence of the walls, and any defective connective tissue and smooth muscle, stretching of the deep fascia, and inheritance of the FOXC2 gene, Klippel-Trenaunau syndrome, Parkes-Weber syndrome. So you can write this classification as etiological classification also. We'll tell about CEAP classification later on. There also etiology is mentioned. So this classification is primarily on primary and secondary basis. So primary varicose veins and secondary varicose veins. And for primary varicose veins, the cause are this is congenital, congenitally defect in wall or congenitally absence of walls, and inheritance with FOXC2 gene. And these are the points that you have to remember from this slide. Coming to the secondary, it is secondary to some predisposing factors in secondary varicose vein. What are those predisposing factors? Post-deep vein thrombosis, occupational factors, the person who is having a job which is demanding for him to sit for a long duration of time. So those are predisposing factors for development of the varicose vein. Prolonged standing, family history, AV malformations, iliac vein thrombosis, any abdominal mass, that is compressing the veins and all, obesity, pregnancy, etc. And the predominance is more commonly noticed in females than males. So primary, we know the causes, it is mostly congenital and familial inheritance. Two syndromes, if you want to remember, you can remember, that is not important. Klippel-Trenaunau syndrome, Parkes-Weber syndrome. Secondary to some predisposing factors will be there. Post-DVT, occupational factors, prolonged standing, family history, abdominal mass, obesity, pregnancy, and it is more common in females than males. Coming to the second classification, it is depending upon the anatomy, we can say. Long or great saphenous vein varicosity, short or small saphenous vein varicosity, or the varicose vein due to the perforator incompetence. That is the second type. The third type is depending upon the diameter of the vein. If it is less than 1 millimeter in diameter, then it is called thread veins or dermal flares. Thread veins or dermal flares. If it is 1 to 3 millimeter diameter of the vein, it is called as reticular vein. And if it is more than 3 millimeter in diameter, it is called as varicose vein. So it is according to the diameter of the vein classification. Once again, I'll just repeat the three classifications. One is we can tell it is etiology, primary or secondary. And second one is long. It is where is the problem? If it is in great saphenous vein or small saphenous vein, or it is in the perforator. Then third is diameter of the vein. It is less than 1 millimeter, it is thread vein. 1 to 3 millimeter, it is reticular vein, and greater than 3 millimeter, it is varicose vein. Coming to the last classification, and this is the most important classification. It is called as CEAP classification. It is having very great significance. So what is the CEAP? C for clinical science, and E for etiology, and A for anatomical distribution, and P for pathophysiology. So that is CEAP classification. C for clinical science, E for etiological, A for anatomical, and P for pathophysiology. Now let's go on to each and everything. C, clinical manifestations. So according to that, there are numbers from 0 to 6 for grading. Classification. So what is 0? 0 means there is no visible or palpable signs of venous disease. That is number 0. What is 1? 1 is telangiectasis or reticular vein. Reticular vein, we know. What is that? 1 to 3 mm diameter of the vein is called a reticular vein. And the second point is given to varicose vein. And if it is written 2R if it is a recurrent varicose vein. So 0, there is nothing, no visible or palpable signs. 1 for reticular vein, 2 for varicose vein, 3 for edema without any skin changes, and the 4 for changes in the skin and subcutaneous tissue along with edema. 4 is again subdivided into 4A, 4B and 4C, and that is not important. If you want, you can remember. 4A for pigmentation, 4B for lipodermatosclerosis, and 4C for corona phlebitis. And number 5 is given for the healed ulcer, and number 6 is given for the active venous ulcer, and 6R is for recurrent active venous ulcer. So this is the C part of CEAP classification. It is, I know it is too much, so many are there. So you have to just know the outline of all these. CEAP classification, C is for clinical manifestations, and the numbering is given from 0 to 6. And what are those numbers? I have just explained in this slide. 0 means there is no visible or palpable signs of venous disease. 1 means telangiectasis or reticular vein. 2 means varicose vein, and 2R is written if it is a recurrent varicose vein. 3 for edema without any skin changes. If the skin changes are coming, then it is called as number 4. And 4 again divided into 3 parts, 4A, 4B and 4C. 4A for pigmentation, 4B for lipodermatosclerosis or atrophy blanche, 4C is for corona phlebitis, and 5 is for the healed ulcer, and 6 is for the active venous ulcer. That's it. Now coming to the E. E means etiological classification. Etiology can be congenital, primary, secondary, or no venous etiology identified. If it is written as EC, congenital, EP for primary, ES for secondary, and EN for no venous etiology identified. Coming to the anatomical classification, AS is for superficial veins, AP for perforator vein, and AD for deep vein, and N is for no venous location identified. So if it is written N, there is nothing identified. So that's it. And coming to the pathophysiology classification, R for reflex, O for obstruction, RP is for reflex, RO for reflex and obstruction, and N for no venous pathophysiology is identified. So N is no, and the remaining you can just correlate. So CEAP classification, this is the CEAP classification. This is the classification now widely used, and it is having the entrance point of view also. It is very important. So let's move on. Coming to the pathogenesis, it is not frequently asked, but if you want, you can remember. There will be incompetence of the venous valve, and there will be stasis of the blood. So there will be chronic ambulatory venous hypertension. Incompetence of the valves, stasis of the blood, chronic ambulatory venous hypertension will be developing, and defective in microcirculation. So the RBCs will be diffusing into the tissue planes, and there will be lysis of these RBCs. Hemocyanin will be released, and there will be pigmentation, and dermatitis followed by that. Capillary endothelial damage will be there, and prevention of diffusion and exchange of nutrients. And if the nutrients and diffusion is not happening, then there will be severe anoxia, and there will be formation of chronic venous ulcer. It is not important. That's why I'm just simply telling this. So pathogenesis they didn't ask. The important thing is classification. Classification they may ask, and they can ask about. So first from the varicose veins, you have to write what is varicose vein, and then you can start with etiology and classification. So both are interlinked. So etiology and classification you can write. So pathogenesis, now you know the outline. And coming to the symptoms. What are the symptoms that the patient will be coming to us while if he or she is having varicose vein? Dragging pain and postural discomfort. Please ignore the spelling mistake here. Dragging pain and postural discomfort, and heaviness in the legs, nighttime cramps, and usually in the late midnight. So the main complaint will be pain. What type of pain? Dragging type of pain, and the patient will be having postural discomfort also, and the patient will be feeling heaviness in his or her legs, and nighttime cramps will be there, and the cramps are usually seen late midnight, and there will be edema in the feet, and they can be itching, discoloration, ulceration in the feet, or painful one. So these are the symptoms by which the patient will be coming to us. Coming to the sign, there are almost a lot of signs, around 8 to 10 I guess, but I'm not discussing everything. That is having practical point of view. So for writing exams, only few are important, and I have taken my points from Arrow Edition 5 notes and some points from SRB also. So let's see what are the signs, important signs that you have to write for the exam. The first and most important one is Trendline test. Trendline test, and the test is having part 1 and part 2. Now let's see what is part 1 of Trendline test. We have to lay the patient down and should lift the leg, and we have to empty the leg and tie a tourniquet below the saphenofemoral junction. So make the patient lie down, lift the leg, empty the leg and tie a tourniquet just below the saphenofemoral junction. Then now we have to ask the patient to stand up, and then we have to open the tourniquet. If the rapid filling is seen from the above, then it is due to the incompetence of saphenofemoral junction. I guess you guys understand. This is the part 1 of Trendline test. What is that? We have to make the patient lie down. We have to lift the leg of the patient. We have to empty the leg and tie a tourniquet just below the saphenofemoral junction. Then we have to again ask the patient to stand up. We have to remove the tourniquet. If the rapid filling is seen from above, it is due to the incompetence of saphenofemoral junction. Coming to the part 2 of Trendline test. Here also we have to make the patient lie down. We have to lift the leg. We have to empty the leg. And we have to again tie a tourniquet just below the saphenofemoral junction. Then we will be asking the patient to stand up. This time we do not remove the tourniquet. If the gradual filling is happening again from the above, then it is due to the perforator incompetence, not due to the saphenofemoral junction incompetence. So this is the part 2. Part 1 and part 2, I guess now you guys clear. Let's move on to the next test. That is Morris's cuff impulse. We'll ask the patient to cuff, and if the cuff impulse is felt at the saphenofemoral junction, then it is due to the incompetence of saphenofemoral junction. Morris's cuff impulse. The name itself says what is it. We'll ask the patient to cuff. If the cuff impulse we can feel at the saphenofemoral junction, then it is due to the incompetence of saphenofemoral junction. The next one is Short's test. We have to tap over the incompetent vein. We have to just tap over the incompetent vein, and if the thrill is felt at the saphenofemoral junction, then it is due to the incompetence of saphenofemoral junction. So 3 tests. One is Trendline test. It is having part 1 and part 2. Then the second one we are told is Morris's cuff impulse. The third one we just discussed is Short's test. Here we are tapping over the incompetent vein, and if the thrill is felt at the saphenofemoral junction, then it is due to the incompetence of saphenofemoral junction. The third one is modified Perthes test. Here we are tying the tourniquet just below the saphenofemoral junction, and here we are not emptying the vein. In all the previous conditions, we have told that we are making the patient lie down, we are emptying the vein, then only we are tying the tourniquet. Here we are directly tying the tourniquet just below the saphenofemoral junction without emptying the vein, and we'll ask the patient to walk. Normally the swelling should reduce, but if the swelling is not reducing and the pain is increasing, then it is due to deep vein thrombosis, because we are ruling out whether the patient is having deep vein thrombosis or not, because DVT is a contraindication for doing surgeries in varicose vein. So that's why we are doing modified Perthes test. So total 4 tests we have told. What are they? Trendline test, part 1 is there and part 2 is there, and then Morris's cuff impulse test we have done, then Short's test we have done, and then modified Perthes test to rule out DVT, and then other tests are there. Fagan's and multiple tourniquet tests are there. So they will denote the site of incompetent perforator. If any incompetent perforator is there, they will be showing those particular site for that perforator. There are various other methods also for testing these varicose veins, and it is available in DAS. Coming to the investigation part. The investigation of choice in varicose vein is duplex scan. What is a duplex scan? Duplex scan means it is B mode ultrasound plus Doppler. B mode ultrasound plus Doppler is called as duplex scan. It is an investigation of choice in varicose veins. In duplex scan, we can identify the flow, direction of flow, reflex, etc. And here it will be appearing as a Mickey Mouse appearance. Like you can see the femoral vein and dead saphenous vein and all. You can see it will be appearing as a Mickey Mouse. Other various modalities for the investigation are Platismography. It is a non-invasive method which measures volume changes in the leg, and it gives the functional information on the venous volume. That is Platismography. Non-invasive method. Then ambulatory venous pressure we can measure, but it is an invasive procedure. Ambulatory venous pressure. Then venography, varicography. What is venography? Venography, ascending venography and descending venography we can do. Before the era of this duplex scan, venography, ascending venography had very much importance. But now, once a duplex scan, that is an investigation of choice, so venography is not done that much. So venography, there is ascending venography and descending venography. Then varicography. Here, non-ionic, isoosmolar, non-thrombogenic contrast is injected directly into the varicose vein, that is not varicella, varicose vein, to get a detailed anatomical mapping of the varicose vein. So a contrast, what type of contrast? Non-ionic, iso-osmolar, non-thrombogenic contrast that is injected directly into the varicose vein to get a detailed anatomical mapping of the varicose vein. And these are the investigation modalities. The main investigation of choice is duplex scan. What is a duplex scan? You have to just mention this B mode, ultrasound plus Doppler. There we'll get to know the flow, direction of flow, reflex if it is there. Everything will get it is appearing as a Mickey Mouse. And then Platismography, it is a non-invasive. Ambulatory venous pressure, that is invasive. Venography we use prior, ascending venography and descending venography. Varicography, a contrast we are injecting into the varicose vein to anatomically map all the varicose vein and all. Coming to the treatment. Treatment we can divide into various categories. One is conservative treatment. What is conservative treatment? Elastic crepe bandage application. We'll be applying the elastic crepe bandage from down to above. About 30 to 40 mm He is provided pressure. And we can elevate the limb to relieve the edema. Unna boats. It provides non-elastic compression therapy and also pneumatic compression therapy we can give. These are the conservative treatment that is given in varicose vein. Once again I will tell, elastic crepe bandage application from angle to the above, like near to the saphenofemoral junction. 30 to 40 mm is provided the pressure. Elevation of the limb we can do, that will relieve the edema. Unna boots, it provides non-elastic compression therapy and also pneumatic compression method also we can use. Coming to the drugs, what are the drugs that we can give for the varicose vein patients? Calcium dobicelate, that is 500 mg BD. It will improve the lymphatic flow and it will relieve the edema. Calcium dobicelate, 500 mg BD. Improves lymph flow and relieves edema. The second drug is diosmin 450 mg plus hesperidine 50 mg. This drug is given to relieve the night cramps, night cramps. Okay. Calcium dobicelate and diosmin 450 plus hesperidine 50 mg. Also we can give toxaroutine 500 mg BD. It will improve the capillary dynamics. So these are the three drugs that is mainly used for treatment of the varicose vein. Coming to the injection part, the main part is sclerotherapy, and there are different techniques for sclerotherapy like Fagan's technique and foam sclerotherapy by Tesserae. And I think it is not, if to explain, there are so much to explain, so in a simplified way I am just mentioning the names only. Sclerotherapy, different techniques are there, Fagan's technique and foam sclerotherapy by Tesserae. There are other methods like microsclerotherapy, transillumination microsclerotherapy, echosclerotherapy, catheter directed sclerotherapy, etc. There are so many methods. Microsclerotherapy, transillumination microsclerotherapy, echosclerotherapy, catheter directed sclerotherapy. So if treatment is asked, conservative treatment, you have to just mention something: elastic crepe, elevation of limb, Unna boots, pneumatic compression. Then in drugs you can just mention the names if you are not remembering the drug dosage and all. Calcium dobicelate, very important. Diosmin plus hesperidine, toxaroutine. And then coming to the injection, sclerotherapy, the word very important. Different technique, Fagan's technique or foam sclerotherapy by Tesserae. Then other methods, microsclerotherapy, transillumination microsclerotherapy, echosclerotherapy, catheter directed sclerotherapy, etc. Coming to the surgery, most important. This is the definitive treatment modality used for the varicose vein. This surgery can be studied as two different kinds. One, according to the etiology, where is the problem, like it is in the great saphenous vein, short saphenous vein, or perforator. According to that we can study, or we can study it as traditional methods or newer methods, or non-invasive methods, traditional methods, newer methods, etc. So in different way we can study the surgery. Here I am explaining according to the etiology and new modality. So first, if it is the incompetence is in great saphenous vein or saphenofemoral junction, what we will do as surgery? If the problem is in great saphenous vein or in the saphenofemoral junction, then the traditional surgery we are doing is Trendline procedure. What is it? Trendline procedure. We know the test is also named as Trendline test, part 1, part 2. So the surgery is also called Trendline procedure. Here we will be doing the flush ligation of the saphenofemoral junction. Flush ligation of saphenofemoral junction is done, and this does not include stripping of the veins. Here 6 tributaries need to be ligated to prevent the recurrence. What are those 6 tributaries? On the medial side we are ligating superficial external pudendal and deep external pudendal. MDL, medial, distal, lateral. 3 subheadings are there. and in overall 6 tributaries we need to ligate. So what are they? In medial, superficial external pudendal and deep external pudendal. In the distal side, accessory anterior saphenous vein and posterior medial thigh vein. Accessory anterior saphenous vein and posterior medial thigh vein. Coming to the lateral, superficial epigastric vein and superficial circumflex ilia. I think medial it is very easy to remember. Medial, superficial external pudendal and deep external pudendal. Coming to the distal part, accessory anterior saphenous vein, posterior medial thigh vein. Lateral, superficial epigastric vein and superficial circumflex iliac vein. This you have to remember and you have to write for the examination. What are the tributaries that are ligated in Trendline procedure? So you just remember once again, read once again and just keep it in mind. But the treatment of choice for this condition is endovenous laser therapy and radiofrequency ablation. We know the traditional surgery is Trendline procedure, but now the newer modalities are available. So now the treatment of choice is endovenous laser therapy (EVLT) and radiofrequency ablation. The second condition, if the incompetence is in short saphenous vein or it is in sapheno-popliteal junction, then what is the traditional surgery? It is a flush ligation of the SPJ, sapheno-popliteal junction, with no stripping. But the latest surgeries are available. They are endovenous laser therapy and radiofrequency ablation. The latest surgeries are same in all the conditions. Coming to the perforator incompetence. If the incompetence is perforators, then traditional surgery is Dodd and Crockett surgery. This Dodd and Crockett name, we can name one perforator is there in this name, Dodd and Crockett perforator. So the traditional surgery is Dodd and Crockett surgery and SCPS, SEPS, subfacial endoscopic perforator surgery. What's it? Subfacial endoscopic perforator surgery. So Dodd and Crockett surgery and subfacial endoscopic perforator surgery. Coming to the later surgeries, that is same, endovenous laser therapy and radiofrequency ablation. There are new modalities now available. What are they? They are endovenous glue therapy and TRIVEX. What is TRIVEX? Trans-illuminated powered phlebectomy. Endovenous glue therapy is available now and also trans-illuminated powered phlebectomy. Not only this much, there are so many different treatment modalities available for varicose vein, but I have just made a simplified slide, the things to write for the examination. We can't write everything and we can't explain everything in that particular time. So if it is asked as an essay, you have to write at least this much, at least. This is the minimum. Coming to the complication part, what are the complications that have happened due to varicose vein? The one is bleeding. Calcification of the vein can occur, pigmentation can occur, hemocysteine, we have told in the pathophysiology. Lipodermatosclerosis, venous or varicose ulcer, scarce of blood, so venous ulcer can occur, and change into malignant. What malignant ulcer? Marjolin, it's not Marjolin's ulcer, it is. Please again ignore the spelling mistakes. I know the spelling mistakes keep happening. So complication, bleeding, calcification of vein, pigmentation, lipodermatosclerosis, venous or varicose ulcers, and it can change into malignant form, Marjolin ulcer also. So these are the complications of varicose vein. I know it's a lengthy module. I guess it's clear now. Like what are the things you have to write for the varicose vein. So first of all, you have to write what is varicose vein. Varicose vein is a dilated tortuous vein with the defective walls. Then you have to write about the classification. If you are not remembering these classification, you can just go for the CEAP classification. And it is not necessary to write everything about CEAP. You can just mention what is C, clinical sign, etiology, anatomical. That is also fine. And then etiological, as the etiology, you can write from this. What are the causes, primary and secondary, and what are those that you can write. And then you can just mention pathogenesis if you want. Incompetence of the valve will occur. That's why scarce of the blood is happening. And there will be defective microcirculation, and RBCs will be diffusing in the tissue planes, lysis of the RBCs are occurring, hemocysteine will be released, pigmentation, dermatitis, and finally there will be chronic venous ulcer formation. That you can just write off. And symptoms will be pain, dragging type of pain, night cramps, edema, itching, discoloration, ulceration, etc. You can write. Signs you have to remember, Trendline test, part 1 and part 2 is there, Morris's cuff impulse is there, that you have to write, and then Short's test you have to write, modified Perthes test you have to write. The etc. etc. Investigation, duplex scan is the most important, and it is the investigation of choice. And Platismography, other ambulatory venous pressure, venography, varicography, you can write. Treatment, conservative, you know what should be written. Drugs, you can just remember the names: calcium dopicelate, diosmin, aspirin, toxirutine. And then injection, sclerotherapy is the important one. And then coming to the surgery, Trendline procedure is a traditional surgery for the great saphenous vein and saphenofemoral junction incompetence. If it is coming to the saphenopopliteal junction and short saphenous vein, you have to write flesh ligation. And then as latest, everything is same: endovenous laser therapy, EVLT, and RFA, radio frequency ablation. So I guess it's clear. So thank you guys, thank you for your time.